Okay. Okay. Hello, everybody.
Доброго дня всім.
I'm Erik Bloemkolk.
Я Ерік Блюмкольк.
I'm from the Netherlands.
Я з Нідерландів.
And I'm director of Soft Tulip.
Я директор організації Soft Tulip.
And we are really happy that we can organize this
Ми дуже раді, що
the second training on COVID-19 rehabilitation. We do this in collaboration with the Ukraine Catholic University, the Faculty of Physical Therapy, and with the Utrecht University for Applied Studies in the Netherlands, also with the Faculty of Physical Therapy. Today's program will be that we will start with a presentation about the rehabilitation of COVID-19 patients when they are hospitalized. This will be done by Jul van Grootel. She's a physical therapist and lecturer at the University of Applied Studies. After her presentation, we will have a presentation about the rehabilitation of COVID-19 patients after they have left the hospital. That presentation will be done by Lucinda de Graaf, also a physical therapist and lecturer at the University for Applied Studies. This will take more or less an hour. Then we will have a short break of 10 minutes so that our translator also can have a break and we all can have a coffee and going to toilet or whatever. And after the short break, there will be a session with questions and answers. You can write down your questions in the Q&A, under the Q&A button. If you click that, you can write there. And you can write in Ukrainian. Irina will help to translate the questions. So this is today's program. We started a little bit later because we wanted to wait for some more attendees to join. But I would like to give the floor to Jul, who will start her presentation. And I wish you all a very fruitful webinar and enjoy. And Jul, the floor is yours.
Thank you, Eric. I hope everyone can see my screen.
We do.
My name is Jules van Grootel. As Eric said, I'm a physical therapist at the University Hospital of Utrecht and a lecturer at the University of Applied Sciences. And today I'm going to take you in the pathway of a patient who is admitted at the hospital. So let's get started. This is about me, just what I said. And what we are going to do is we're going to discuss what happens to a patient who is admitted at the hospital for COVID-19. And there are two pathways, actually. The first one is a patient is admitted at the ICU, the intensive care unit. And the other pathway is that a patient is admitted at the cohort unit. It's a nursing ward. Sometimes the patient is first admitted at the nursing ward and then goes to the ICU or otherwise. Patients always go from the ICU to the nursing ward and then to another, sometimes to go home. Last lecture was more theoretical, and this one is more about a patient. And Lucinda and I chose a patient to talk about, and the patient we're going to talk about is Mr. Jones. He's 65 years old, a male and retired. he got COVID infected, and first he was 10 days at home where he got infected and he was ill, and then it became worse and he was transported to the hospital. Okay, then we are in the hospital, and then he was admitted to the ICU for 5 days. Important is to know that he was not intubated and he was awake during the ICU phase. After he left the ICU, then he was 10 days in the nursing ward before he went home. So keep this case in mind. I will let you read it for 1 or 2 minutes so that you could know which what we are going to discuss. Mr. Jones, a male infected by COVID, 10 days at home, 5 days at the ICU, and then 10 days at the nursing ward. Okay. When we are at the ICU, we're going to check on Mr. Jones, and we're going to evaluate if a patient is able to undergo a physiotherapy treatment, because not every patient is able, because instability or other problems. So we always stay in close contact with doctors and nurses, and we will ask them if is Mr. Jones able to undergo a physiotherapy treatment. If that's not, we explain it in the patient's medical file that we tried, but the patient wasn't able to undergo the treatment, and while we come back 2 days later to evaluate again, and again, and again, and again, until he's ready for the treatment, and then we will start with the treatment. So it's very important that we report in the patient's medical file what we are doing, also when we're doing actually nothing, just waiting. Last time we talked about the sedated phase at ICU, but in this case the patient is awake, so he's not sedated, he's not intubated, so this phase we can skip with Mr. Jones. Then we go to the awake phase. And that's when we're going to start, because this is needed. He is non-invasive ventilated, and he is in prone or supine position, but he's awake, so we can do anything with him. First, we're going to check the breathing pattern and if there is any mucus. Because Mr. Jones have never had lung disease before, he is not aware of any problems probably. So we're going to check the breathing frequency. If there is any mucus, we're going to check the cough strength and maneuvers. And we're going to mobilize him, and we're going to train the strength of peripheral muscles. But first we start with the breathing pattern. And that is what we last time also discussed. So you will receive the movie in the PowerPoint, but we're going to count the breathing frequency. We're going to measure the oxygen saturation. We're going to measure the heart rate, and we're going to take a look if he is able to inhale and exhale deeply. So that's what we're going to try to do all now, is try to breathe in, hold your breath, and relieve it. I'm going to do that again. So breathe deep in, hold it for 1 or 2 seconds, and exhale deeply. That is what we're going to ask Mr. Jones. And we're going to encourage him to breathe in the best he can. So deep in, hold it, and then we call it pursed lip breathing. Let the air go through your lips through a small opening. So like a little blow. Thank you. So there's a little bit pressure in your mouth. We're going to do it again. Deep in, hold it, and this is very hard for Mr. Jones. Sometimes he needs to cough during this exercise. but that's no problem because it can also cause that the mucus is going up actually. If Mr. Jones is able to do that, we're going to make a further step in the breathing cycle. We're going to breathe in, hold it, and with the mouth a little bit open, we're going to breathe out. And I tell Mr. Jones, okay, pretend that you're in front of a mirror and you want your oxygen on the mirror, just like this. And extend the exhalation. So deep in, hold it, and breathe out. Another time. Breathe in, hold it, and another time. If Mr. Jones is able to do this, then we're going to give him compliments and we're going to let him repeat this because this is very hard. When Mr. Jones is getting too tired of this, we're going to stop because we know this is very hard to perform. If he isn't tired, then we go to the next step. It's almost the same as the second step, but we're going to do this. Deep in, hold it, and with maximum of volume, you're going to breathe out. Like this. Okay, we're going to repeat that again. Breathe in, hold it, and breathe out. Last time. Hold it and breathe out. And that is how we try to cause that the mucus is going in the mouth and he can spit it out or swallow. That's no problem. So we have 3 phases. The first phase is, we call it the pursed lip breathing. That's what you will see in the movie. Little bit of pressure in the mouth, like this. The second phase is breathe deep in, mouth wide open, and extend the exhalation. The third step is breathe in, hold it, and force the exhalation. Okay, if a patient is able to repeat that, then you're going to ask him, do that as much as you need it for a day. When there's a lot of mucus, patient perform it like 10 times a day. When there is a little bit of mucus, 3 times a day is enough. We would like that in a sitting position because we know that's the best way to get rid of all your mucus. Breathing frequency, you have measured it, and sometimes we see that the oxygen saturation will improve after these exercises because patients get rid of their mucus. Okay. Now, we have focused on the airway clearance techniques. That's what we did before the first dia. But now we're going to focus at the peripheral muscle strength. At the ICU, we have to measure this. And we measure this with the MRC sum score. And this is what you see. On the left side, you see the muscles involved. And on the right side, you see the score. So arm abduction, you measure it like this. And if a patient can, if you see no movement, they score 0. And if they have normal power, so they can perform it against resistance like anyone else, they get a score of 5. You test it for every side, so left and right. And you sum all the scores, and if it's like 60, you have normal score. Is it less than 48, then you have a very low score, which can result in ICU acquired weakness. It's extremely weakness of all muscles, mostly lower body, caused by the ICU admission. So on the left side, all the muscles involved, the first 3 are for the upper body and the last 3 are for the lower body, and right side, the scores. And Most of the patients we see have a MRC of 2 or 3 per muscle. You measure this every 3 days, but remember that in this case, in Mr. Jones, this can differ each day. So when you measure it in the morning, it can differ from measurements in the afternoon. And it depends on who measured the patient. So it's important that if I measure Mr. Jones, that I will do that tomorrow and the day after and the day after. When it's stable for a few days, then we do it every 3 days. Okay, and the third thing we're going to do with Mr. Jones is we're going to mobilize him, because we know that is the best way to keep them strong and get to the nursing ward. In this dia, you see 3 ways of mobilizing the patient, but Mr. Jones is awake and was not admitted at the ICU for a long time. So he can mobilize on the right picture in the chair. What you see on the left was what we discussed the last presentation, and it's for very weak patients who aren't able to stand up from themselves, but Mr. Jones is able to stand up with help from the nurses or the physiotherapists. What you see is that he has a plate in front of him. This helps him to find a position in the chair, and he can put some things on it. So if he get exercises or some drinks, he can put it on it. And as you see, the chair is very stable with a pillow in the neck, so the head will be, I don't know how to say it. Anyway, there's a pillow in the neck which helps him sitting in the chair. Okay. And we give Mr. Jones some exercises mostly for the lower body. And these exercises need to be high weights and less repetitions. So on the first picture, you see leg press, kind of, but it's for in bed. And patients perform it each leg, and the physiotherapist puts it on the bed so to train the muscles of the lower body. But Mr. Jones was also able to sit in the chair. So we give him exercises to strengthen his leg in the chair, 3 times 8 repetitions, and he can perform it during the day. So we also tell it to the nurse that he is able to perform some exercises, so they keep reminding him of it. When Mr. Jones performs these exercises on the ICU, after a few days, he is stable enough to leave the ICU and go to the nursing ward. And he is still non-invasive ventilated, and he is able to recover on a nursing ward. So we still keep trying to measure his oxygen saturation, his heart rate, his breathing pattern, and we're going to remind him of the airway clearance techniques, which we just practiced. But now the goal isn't to get rid of the ICU, but now the goal is to go home. So we're going to mobilize him further than only to the chair. What we do is we give him a daytime program. We're going to pretend that he already is at home. So he has to try to eat his meals while sitting in a chair, sometimes on the bedside, but we prefer sitting in a chair. Mr. Jones needs also to sit in a chair when his wife is visiting him. So he can hold a conversation with her, and he has to rest 1 hour after lunch. So we make appointments with our patients. We try to at the same times each day, so he knows when he has to perform for physiotherapy, when he has a pause to take a nap or to rest, or when his wife is able to visit him. and the nurses keep reminding him of this daytime program. Then we have the exercise guides. These are movies who can see a patient on an iPad, but we also have it in folders for Mr. Jones. And the left one is the workout in bed, the middle one is the workout in the chair, and the right one is the workout standing. So Mr. Jones performs the left workout in bed in the morning when he's still lying in his bed. And the middle workout he performs in the chair. And the standing workout, he is only allowed to perform it with one of the physiotherapists, because we want to measure the oxygen saturation during this workout, because it's quite intense for him. When the oxygen saturation is stable, then it's no problem and he can perform the workouts by himself. When the oxygen saturation is below the level we wanted, then he needs to take a little bit of rest and he's not able to move out of bed or chair. That depends. But after a few days, Mr. Jones is getting more stable. So he is able to walk in his room and he is able to perform the standing workout, and he is able to sit in a chair for more than 1 hour, and he's getting better. So he wants to move more because he wants to go home. Every time his wife is visiting him, he wants to go with her. But before he is allowed to go home, he has to practice daily activities. First, he walked with a walking aid during the admission, but now he is able to walk without it in the room, and he isn't allowed to leave the room, so we can't practice walking for a longer time. So there are short times when we walk, but he don't need the walker. But he is also practicing to prepare his own food. So making lunch kind of things, getting a glass of water. And we are trying to walk the stairs because that he needs to walk a stair in his house. But it's quite hard because not every room has stairs. So we bring a step to the room, and then we can perform the exercises like 13 times so he can walk the stairs. And during these exercises, we also measure oxygen saturation and heart rate, because this is the phase that he's almost going home. So it needs to be stable also at some hard activities. And the best exercise is to get standing up from a chair and sit down and repeat it for very many times. It's a good exercise for the muscles, and it's a copy of the exercises in daily life. When Mr. Jones is able to walk the stairs, then actually almost every physiotherapy goal is reached. So we can take a look what he's going to do when he's home. He has to be able to walk independently without aids inside the house. And he can stable walk inside the house, but not outside the house. He can walk the stairs, and his wife can take a little bit of care of him. But he has a lot of pain in his left arm and hand. So that we need to work on. He bought a walker for walking outside the house, and he bought a pulse oximeter to measure his oxygen saturation at home, because he is curious what happens when he is a week at home. The Emerson score when he left the hospital has a score for each leg, or each muscle actually. And left and right are not the same because of the pain in his left arm and hand. The left side is a little bit lower. Because of his muscle weakness, he also had a muscle trainer from the hospital, and he uses it, but he still keeps we need to keep reminding him of it. As a physiotherapist in the hospital, when somebody is going home, we're going to write a letter for the physiotherapist in his city where he lives. So we give some advices, we write a short letter, what happened during the ICU and in the nursing ward, and we give a summary of the advices for being at home. So sometimes it's a copy of their workouts. And with all that information, Mr. Jones can recover at home and follow physiotherapy at his house. And that's what Lucinda is going to talk about. But I think it's good to know that the patients the recovery at the hospital is not only about muscles and mucus and coughing a lot. It's also about confidence, because Mr. Jones is very ill, and he had never been this ill before, so he don't know what to expect. He don't know how long it will take to walk with his wife in the garden, or how long it will take to do some grocery shopping. And he needs a lot of rest, because most of the patients think admission at hospital is like a roller coaster. So there happens a lot of things in very small amount of time. So that's what we tell to Mr. Jones. First, go home, then take a few days rest, and then go to your physiotherapist and make a plan for yourself. What do you want in a few days, few weeks, and a few months, and then going to work on it. So this is what I want to tell about the hospital phase. Thank you for your attention. I'm going to quit my screen. And then I think Lucinda is going to follow.
Yes, I will. I will share my screen. Let's see. Yes, you can see my screen, right?
Yes.
Okay. So thank you, Jules, for the introduction of Mr. Jones. I will talk to you about the rehabilitation when Mr. Jones gets home after hospital admission. And mainly I will focus on the measurements and the exercises and home exercises Mr. Jones gets from me. Something about me. It's already told, but I'm a physical therapist and I work at Physio House in the Netherlands. I'm specialized in lung diseases, orthopedics, and recently COVID-19. We have about 90 patients so far in our practice. 20 are from the ICU. There are 50 patients, I guess, from home COVID, who gets COVID at home, and the rest is only been to the hospital for a few days or a few weeks and not been to the ICU. I also am a teacher at University of Applied Sciences, but today I will talk about physical therapy. This is a picture I showed in the first webinar about the three different COVID types of patients: home COVID, cohort, and ICU. And today I will talk about the intake, the measurements, and the start and evaluation of the rehabilitation the physical therapist does. When we start with the intake of Mr. Jones, first I will tell you something in general about COVID rehabilitation, and then I'm focusing on Mr. Jones again. The main focus of physiotherapy must be the patient's personal needs and request for guidance. And also it must be about the perceived limitations in physical functioning. We divide two phases. Phase 1 are the first 6 weeks after hospital discharge or illness at home. But for now, we're going to talk about hospital discharge because of Mr. Jones. And phase 2 are from 6 weeks till the end of the rehabilitation. Sometimes it takes like half a year, sometimes 9 months. We don't know for sure with every patient. There are clinical outcome measures to use in phase 1. So things you measure within each patient. The first one is the patient-specific functioning scale. We also measure oxygen saturation and heart rate frequency. We test a 5-time sit-to-stand test. We also use the handheld dynamometer for grip strength, and the Borg scale, CR10 for shortness of breath and fatigue. We measure every patient who's in our practice. We measure at week 1, and we also measure at week 6. So first we measure, we give therapy, and then we measure again to see if the patient gets any better. I will explain some measurements for you. The patient-specific functioning scale is a questionnaire where you ask the patient to write down 1, 2, 3, or 5 different activities which he or she wants to be able to be doing again in the future. You rate them from 0 to 10. 0 is unable to perform, and 10 is able to perform the activity. After 6 weeks, you will ask the questions again to the patient, and then you can see if there is any improvement. So the minimum detectable change for each single activity must be 3 points. So if a patient gets from 0 to 5, that's a detectable change. So that's you can say that he gets better from the treatment. We also measure oxygen saturation and heart rate frequency with a pulse oximeter, same as you used in the hospital. We also do the 5-time sit-to-stand test. I will show you. This is my colleague who is showing you this test. It's a simple test to determine the muscle strength. You ask the patient to get up from the chair 5 times as quickly as possible, and you record the time in seconds. Now, start again. This is the handheld dynamometer. It's a Yamar meter. You determine the isometric muscle strength from the patient. You let the patient sit in the chair with his arm in front of you, so you can see what he is, how many force he will is putting on the device. So you can read the newtons on the device, and by measuring the maximum hand grip strength, it gives a good estimate of the muscle function, and it's related to the total amount of muscle mass in the body. The Borg scale CR10 for shortness of breath and fatigue. It's a rating of perceived shortness of breath during an exercise, and also the fatigue or exertion when you perform an exercise. And it's widely used as a reliable indicator to monitor these two things. You let the patient give a ranking between 0 or 10. Well, you can see the different numbers on the screen. So the first 6 weeks when the patient gets at home, we start therapy and focus on promoting activities of daily living, increasing muscle strength and balance, physical endurance. We also focus on relaxation and the breathing exercises, which most patients already have practiced in the hospital. During the exercise, you use a score of 4 on the Borg scale. So if a patient has a score of 6 or 7, you have to stop the exercise or make it a little bit more simple. You also monitor oxygen saturation and heart rate. You do this at rest and during and after the exercise. And we use 90% saturation as a lower limit, and during physical exertion, an absolute minimum of 85%. In case the saturation level is decreasing, it's important that the saturation levels reaches the pre-activity level within 2 minutes. And you have to be alert of signs of physical or psychological overload in the first 6 weeks within these patients. Then after 6 weeks, phase 2 starts and we measure again. The same measurements we did at week 1, but there are 3 more measurements, which you will see in the green area. That's the 6 minutes walking test, the one repetitive measurement, and the pedometer or the accelerometer. So these 3 measurements are added to the data set, and we also write a letter with status quo to the doctor or general practitioner of the patient. So then in week 6 we measure, and after this we give therapy again, and we measure at 12 weeks, 26 weeks, or as many times you want to measure the patient's progress. A little bit about the 6 minutes walking test. This test is used to assess the gait pattern and the walking speed and the endurance of patients. You can use a distance of 30 meters. You can also use a distance of 10 meters. There are 2 types of 6 minutes walking tests. You measure the maximum distance a patient can walk within 6 minutes. We also measure saturation and heart rate frequency during the test, and a patient can use a walking aid and an orthosis during this test. The one repetitive measurement test is a test where you measure muscle strength. It's a maximum load. It's the maximum load you can perform a movement with the correct practice technique for 1 repetition. For most COVID patients, it isn't possible to perform the 1 RM test. So if a patient does a test like 10 times, you can see in this figure that that's 70% of the maximum. So you can calculate the 100% 1 RM when a patient gives 10 measurements of 10, how do I say it in English? When a patient does the exercise 10 times, you can measure it to the 1 RM measurements. This is a pedometer. There are different devices. You can have devices to wear on your trouser, or apps on a phone or a smartwatch on the wrist, but you have to count the amount of steps a person does in daily living. So after 6 weeks, the therapy focuses on promoting activities of daily living and participation. It also focuses on muscle strength and balance, physical endurance, relaxation, breathing exercises. And during the exercise, you can go to a maximum score of 6. So in the first 6 weeks, you go to a score of 4 on the Borg scale, but now you can go to a score of 6 on the Borg scale for both shortness of breath and exertion. And for the exercises you perform, there is an intensity of 60 to 80% of the maximum exercise performance you tested in your measurements. Ensure that there will be a gradual increase in training frequency, intensity, and also time and duration. But this all, it's all based on the patient needs and his physical abilities and his treatment goals. So when we go back to Mr. Jones, this is the first time I saw Mr. Jones. So it's a status quo when he got home from the hospital. Well, he's still 65 years old. He lives with his wife. He can walk independently without aids inside the house, and he's not able to mobilize outside the house. He lives with his wife. He has a house with stairs, a bathroom, and a bedroom on the first floor. He has no home care. His wife takes care of him, and his wife is also still working 2 days a week. He has three children, 4 grandchildren, and sadly, one child passed away 6 months ago, just before he got COVID infected. He has a few hobbies. He likes to walk outside 4 times a week for 2 hours, a maximum. He also likes to do gardening, and he likes doing things with his children, grandchildren, and wife. He has a lot of pain in his left arm and his hand. It's a pain score of 5. He has also a walker to walk outside, and he bought a pulse oximeter to check his saturation and heart rate frequency at home. His muscle strength, his legs are MRC4. He also got a breath trainer from the hospital, and his medication, his pain medication for the pain in his arm, and he has usual heart medication. But this is a status quo where I saw Mr. Jones for the first time. At week 1, I did measurements. The one I showed you before. This is what his scores are. So he could not walk independently outside. He could not drive a car or go on a bicycle, and he could not do his gardening. His oxygen saturation and heart rate frequency in rest are 95% and 89. He has a 5-time sit-to-stand test of 42 seconds. That's a lot, because within the 5-time sit-to-stand test, it's when you score more than 14 seconds on this test, and there's a possibility of falling, so that the patient is not able to walk safely outside. The score on the Yamar meters are on his right hand 32 kilograms and on his left hand 18 kilograms. Borg scale for shortness of breath was 7, and fatigue 8, and this was for walking in the house and wash and dress himself. He also has a pain score for his left hand and arm of 5. So in the first phase, like the first 6 weeks, I told Mr. Jones that we start the exercises at home. So he got an e-health program to do 3 times a week. He must start walking outside with a walker. We start with 5 minutes, and then we extended it till 30 minutes a day. And he also must do his breathing exercises and his breath muscle exercises. We use the pulse oximeter to monitor oxygen saturation and heart rate at rest and during and after the exercises. And because it was a 10-minute walk, so when Mr. Jones could walk for 10 minutes, he could come to our practice, and we started our exercises there. He also got occupational therapy from a colleague of mine. So what did we do with the e-health training program the first 6 weeks? I hope you got the PDFs of the e-health training program. If you do not, you can ask Eric afterwards, but there are a few exercises we do. It's mainly for lower and upper body strength. You can see the exercises over here. I think they will show themselves. So if you read them, you will you can give them to your patients, or you understand which exercise is meant on the e-health program. So Mr. Jones started with it at home 3 times a week. He also has a breath muscle trainer. In the Netherlands, we have 2 types, mainly 2 types. A patient gets from the hospital, a 3-flow or a Mediflow. I also have a Mediflow here. You can place your mouth around the 3-flow or the Mediflow and breathe in deeply and for a long time. You should breathe deeply and steady, aiming to keep the orange ball or the 3 different balls floating for as long as possible. And to exhale, you remove the mouthpiece and release your breath. So this is a breath muscle trainer. The occupational therapist in my practice told Mr. Jones to focus on daily energy distribution. And she also told Mr. Jones to, she gave him some tools to use his left hand again with less pain. And after 3 weeks, he started cycling outside. So she went outside with him to see if this is possible or not, if this is, if it was dangerous, or if he could do it by himself. So we trained 6 weeks with Mr. Jones at home, and the last 2 weeks he came to the practice. And then I measured Mr. Jones again. So I did the same measurements again on week 6. We call it T1. And you see different scores. He gets better, like walking outside. I got from 0, impossible, to 3. And he also likes to drive a car and bicycle. He gives his score 5 because the bicycle is possible, but the car isn't still. He also likes to do gardening at his daughter's house, and that's, he scores a 7. So that's, we came from a 0 to a 7. That's a lot of improvement. His oxygen saturation in rest was 96, and his heart rate frequency was 74. So that was also better. He performed a 5-time sit-to-stand test again, and he got from 42 seconds to 26 seconds. So that's a lot of improvement. He did it a lot faster than the first time. He also gained some muscle strength, because the dynamometer showed that his right hand gained muscle strength from 32 kilograms to 36 kilograms, but his left hand was exactly the same. Borg scale also lowered from 7 to 3, and fatigue from 8 to 4. And the pain in his left hand got a little bit less, from 5 to 4. We performed 3 extra measurements, the 6-minute walking test. He walked 256 meters. That's 45 of what it used to be for his height, his length, and he's a male. I also performed an RM test on the leg press. It was 83 kilograms, and he walks around 4,000 steps a day. So the first 6 weeks were mainly at home, and then we started in our practice in the second phase. He still has to do e-health exercises at home 3 times a week. He walks and he cycles every day 30 minutes. He also still must do his breathing exercises and his breath muscle exercises. And he performs an exercise program in our exercise room 2 times a week. So it looks like the same e-health training program, but there are a few different exercises. They got from seated to standing exercises. These exercises can be done safely at home by the patient. That's why we do this at home, and we do other exercises in our exercise room. These are different types of exercises I do with Mr. Jones. We do interval training on a bike. This is mainly aerobic, anaerobic, from 70 to 90% of heart frequency maximum. You can measure these rates. We use a ratio of 2 versus 1, like 2 minutes of aerobic is 1 minute anaerobic. And we do this cycle 4 to 8 repeats. We also do weight training for the upper body and the lower body. On the right side, you see our device. It's a kinesis. I don't know if you know it, but you can do a lot of exercises with the kinesis. You see my colleague Onno again, and he's performing some exercises like a horizontal row, a chest press, or a low row. For the lower body, we do a leg press, a squat exercise, or a step-up exercise. And for the weight training, we use 60 to 80% of one repetitive measurement, 10 to 20 repetitions, 3 to 4 repeats for every exercise. So when Mr. Jones comes to our exercise room, he is there mainly for 1 hour, sometimes a little bit more, 90 minutes. So it's 2 times a week, 60 to 90 minutes. That's a lot, but he gets better. So that's what we do, for instance, because every patient is different. Every patient needs different exercises for balance or for muscle, from core stability training to upper body training. But what you need to know is that every several weeks, like week 1, 6, 12, 16, or probably 26, you measure the patient again and again to see if there's any improvement. So when therapy goes on, we hope that all measurements will keep getting better in time. So at the end, we have healthy, happy patients again who can do whatever they want with less, how do I say it? Now, the main focus is to...
Effort?
Yeah, it's not effort, it's with the restverschijnselen.
Rest complaints.
Breast complaints. Okay, yeah, that's it. So we have healthy patients with no limitation.
Side effects.
Side effects from the COVID
long-term
infection.
effects.
Yeah, that's what we want. So thank you for listening. We have a short break. You can put the questions in the chat, I guess. And after that, Jules and I will answer your questions. Or
please. Already one person wrote down a question. I would like to motivate all participants to use the break to formulate their questions and write them in the Q&A. What also is a possibility, as we have not a big group of attendees, you can use, if you prefer to raise a question live, verbally, you can raise your hand, and I'm able to see that, and I can give you the microphone. So then you can present your question live, and Irina will help with translation. But please, first of all, write them in the Q&A, and we will go through those questions first. So thank you very much, Lucinda, and you for your wonderful presentation. And now we will have a 10 minutes break. So it's in Ukraine 18 plus 5 minutes. So please come all back in 12 minutes. So at 18:15, and in Netherlands 17:15. So I hope to see you all back in 10 minutes. And Irina, thank you very much for your translation so far. Please have a good cup of coffee and a good break, so your brains can rest. Thank you. Okay. Recording again. Okay. Thank you for being with us. This is the last part of the webinar. We will first go through your questions, and we will end the webinar with a short poll with 5 questions. because we want to evaluate this webinar. So we need your feedback on that. And so I made some 5 simple questions. So it will take 3 minutes or so to answer them. So please stay with us also at the end to fill in the poll. So we have until now one question. It was a question from Natalia Ivasic, and it is a question about what caused the pain or causes the pain of Mr. Jones. Why his left arm is so painful and his hand is so painful?
Yeah, I already wrote it as an answer, but you got a few examinations in the hospital, and there's muscle dystrophy in his left hand. So he is referred to the hand physical therapist in the hospital. And I think he went there yesterday, so I don't know what they will do with this, but maybe Shu knows a bit.
Not exactly, but you can imagine that a patient is lying in his bed for many hours or days. So we know that if some muscles are able to recover, we need to move them. So we need to move the hands or we need to move the arms. But when a patient is lying in one position, the recovery is delayed. So that's why also pain can be there for a longer time, because he hasn't moved his left side a lot. Yes.
Okay, great. Are there any participants who would like to raise a question verbally? So they can raise their hand. Checking. If there are any questions? Was it that clear? It were very clear presentations. Even I'm not a physical therapist or anything like that. I think I could understand most of it at least.
Well, I would like to know who are the attendees. Are there students or doctors or?
Oh, well, there's a question. I will allow to talk, and first I will switch to, yeah, okay, allow to talk. Yes, there's a question from, I cannot read, it's in Cyrillic. Corina? Can you talk? You can talk.
Ви мене чуєте?
Yeah, I can hear you.
Я хотіла запитати, чи дуже сильно відрізняється програма фізичної терапії в кожного пацієнта? Ну, тобто просто індивідуальність, це зрозуміло, що має бути для кожного пацієнта, чи програма, вона дуже сильно відрізняється, чи це лише малесенькі деталі?
Okay, can you ask it again? In the English translation, sorry, I translated.
I don't hear an English
channel,
translation.
so I can hear you. Yeah, I can.
I have to say it in English, or?
Yeah, it differs because we ask the patient.
Ik heb niks gehoord, Lucinda, dus antwoord jij maar.
Ja, oké.
Oh, I will ask. Oh, sorry. Can you hear me? Okay. Yeah. It differs because every patient. I will switch to the English channel. Sorry.
Yeah.
But it differs because every patient wants to do other things. So this Mr. Jones wants to do gardening and walking and cycling. And that's probably more easy than a COVID patient who wants to go back to basketball or play soccer again. but mainly it's the exercise programs are the same. We train upper body, lower body, core stability training, also endurance on the bike or during walking. And it's a difference because sometimes I give a patient a squat oefening or exercise, and sometimes I give a patient a lunge exercise because he wants to do gardening, so he has to go to the ground. And some people do not have to plant little trees on the ground. So yeah, mainly it's the same. Lower, upper body, and core stability training. That's the main goal. But the difference between Mr. Jones is 65. I have a patient who is 13 years old. So I can let her perform more challenging exercises than Mr. Jones.
Okay.
I hope.
Thank you. Other questions? Please raise your hand by using the button on the Zoom lower part of the Zoom screen. There is the raise hand function. If you have any question. Natalia says thank you, Jacques, for the answer to her question.
Mm-hmm.
Oh, there's another question. Oh, also Lilia says Jacques. That's what I can read.
I translated it. Yeah.
Translated it.
Thanks for the answer.
I recognize.
I translated it. Thanks for the answer. Okay.
Thanks for the answer. Okay, great. Okay. No other questions. It was all that clear. If not, then we will do the poll, because no questions coming in. So, well, I consider this as a big compliment for the presentations. I'm recording this session. It temporarily it will be available on the website of. I will put it on the website of Soft Tulip. You can send a request to the email address I put in the chat for both the files of the exercises and for the recording to see it back, or for a colleague who could not attend. Now I will. Where's the poll? Oh, there. I will start the poll. So please provide us with your questions. So first question is about the satisfaction for you as participants about this seminar. How relevant was the content? Oh, here I launch the poll. No viewing question. Okay. So you can vote now. See a lot of very relevant and relevant coming in. 85% has voted. 100% has voted. Thank you. 71% very relevant, and 29% considered it relevant. So that's very nice. Thank you very much. I go to the second question. It's also about satisfaction. It's about the length of the seminar. Can you please start voting now? Was it too long, long enough, too short? 51% has voted. 85. 85% has voted. Okay, one more person should vote. Okay, yeah, everyone has voted now. Thank you. Oh, 67% considered long enough, and still 33 too short. So they wanted to have more information. That's nice. Thank you.
Maybe we should talk all day, Chu.
Yeah.
Then we go to question 3. Do you think you will be, oh, I will launch the poll so you can see it. Will you be able to use the information? Yes, no, or don't know yet. So please give us your opinion. Okay, 100% has voted. 50% exactly yes, will be able to use the information, and don't know yet the other half. Okay, great. Thank you. Then we go to the last question. Would you like to receive any further training? Oh, 100%. Yes. Oh, thank you very much. It's very kind. Okay, great. Well, that's very nice to know. Here are the results. Okay, I will download the results now for myself. Okay, stop sharing. Stop the poll. Okay, well, thank you very much. We are right on time. The webinar was planned for 1.5 hours. So it's nearly 6:30 in Ukraine. So I'd like to express again my gratitude to you, Lucinda, and Irina, who all 3 volunteered to give this presentation. So thank you very much for your efforts. I think it is, of course, a very important topic during this pandemic. So I hope you all enjoyed participating, listening to the presentations, and also hope the presenters enjoyed. And a big applause for the presenters and Irina. Thank you for your efforts, and hope we'll be back soon with another training, because the conclusion was you really would like to have another training. So we will talk about it and see if we can organize some more. So have a good day. Use this information. Write email to me, can be in Ukrainian. Google Translate helps. And again, Irina, thank you so much for your translation service. So bye-bye to you all. Do побачення.
Bye-bye.
Thank you.
Bye-bye.
Bye.
Bye-bye.